If you would like to ask a question, please head to Slido and use the event code hashtag GoshConf1.
Thank
Susan,
you
over to
so
you.
much. Thank you so much, Sharon. And it's an absolute pleasure today to be able to explain to you how I've been able to involve patient and public involvement in my AI project here at Great Ormond Street. Currently, I'm working on a project trying to develop and test AI tools to look on X-ray images for fractures in children's imaging. You will have heard this morning from Professor Andrew Taylor that research is care and care is research. And here at Great Ormond Street, one of our guiding principles is to put the children and young people first and always, and that carries through whether it's care or research, and very much so the case in this research project that I've been involved with. So, this story goes back to 2020 when I was thinking about applying for a grant for this particular research study. And right from the start, it was really important to seek patient and carers' opinions up front in what they thought about how AI could or couldn't help in this particular use case. So I started by contacting the PPIE manager for research, Deirdre Layden, who put me in touch with a great group of young people and also their carers and guardians through the YPAG and PCAG group here at GOSH. And at that time, it was really at the start of COVID. And so these were one of the first few meetings that were held on webinar with the group. They usually used to hold them face to face beforehand. So we were a little bit nervous at the start whether or not this might translate well and whether or not this group interaction and feedback would be applicable for this kind of work. And actually, it worked amazingly well. A lot of the young people who were probably a little bit shy to speak up made very, very good use of the chat, liked to give me lots and lots of feedback. I came away with so many opinions on how I should take this research project forwards. What I shared with them about the project was this. I said, when children break a bone or fall down or hurt themselves in the UK, there are quite a lot of them that do this. And when this happens, they go to their local hospital and get an x ray taken of the particular arm or leg or area that's hurting. Usually, someone like myself, who's a specialist in medical imaging, would look at that and be able to give an expert opinion right there and then in the ideal world. And then, whoever the doctor is or nurse looking after them in the emergency department could make a decision about whether or not they should go home, have a cast, or be referred on for an operation. However, the reality in this world that we live in is that actually a lot of hospitals don't have access to a specialist. More than half of them don't have this. And the ones that do are really dotted around the country. So there's a lot of geographical inequality, which means that sometimes the doctors and nurses on the shop floor don't have this expert opinion to hand, and they have to come up with a decision themselves. And whilst they're all very good and trying really hard, they're very busy and very distracted. And 10% of the time, they may get the answer wrong because they're not looking at these cases all the time and they've got many, many other things on their mind. And the impact of that is that children who may have broken a bone but get missed, maybe in pain, maybe in discomfort, may end up having much more severe disabilities because these bone problems aren't treated early enough. It also means that they may be in pain for longer, take more time off school. Their parents might have to take more time off work, and they may keep coming back saying, I don't know what's wrong. It still hurts. Tell me what to do. Tell me what to do, which is obviously wasteful for everyone involved. And finally, another thing that's really important in children's healthcare is that although the fracture, if it's not that severe, may not necessarily be a huge impact, but if that fracture is related to some safeguarding issues, such as a marker of child abuse, then that can be hugely important to pick up because it could be fatal. So we really don't want to be missing these fractures for a lot of reasons. And I said to them, in a more innovative, digitally enhanced world, perhaps we could create an artificial intelligence that once it sees the x-rays, puts a box around the area where it thinks there's a broken bone, tells you immediately, and if it could be as accurate as an expert, then we would get answers faster. The doctors and nurses would be able to be more confident about the decisions they're making, and hopefully we'll have better outcomes for our patients. So I asked them what they thought about this and how they felt, and this really guided the research plan that we put forward for a grant funding application. The sorts of things that they said to me were, They really wanted computers and humans to work together, not separately. They really liked doctors and nurses to still be in the loop and not to be removed from this process. So we wanted something that could aid and enhance humans rather than replace them. They really felt that patients' views were hugely important and kept front and center. So they suggested that a website or some kind of update or blog could be created so that patients who are interested in AI could be kept up to date with the progress of the project. We also thought about how we could get more voices from more children and young people around the country involved. And so we thought about potentially including a survey of opinions. We also thought that actually, in terms of identifying fractures, it's not so important necessarily to say whether one was there or not if it didn't change what would happen to the patient. So, one idea was to include an extra work package to this study, which focused on whether or not doctors and nurses or healthcare staff would change what they do as a result of what the AI said. So, that became an extra component to the research plan as well as part of this discussion. We cemented all of this, came up with an agreed plan, and this was published in the Impact Case Study back in 2020, 2021, a publication from Gosh. And I'm really happy to say that with all of these changes and the input and additions to the research plan, the study was successfully funded and awarded in 2021, and we called it the Fracture Study. So, one of the first things based on the feedback was to set up some branding and updates and create a kind of persona for the study. And one part of that was trying to create a logo for our particular fracture study plan. So what we did was I created a couple of designs that I thought might encapsulate the idea of a broken bone and a neural network that would highlight that this was about broken bones and about AI. And I put it again to the YPAG group at another future meeting afterwards and asked them for their opinions. So these were the two logos that eventually made it to the final decision. And I put this to the group in 2021, 2022, and asked them for their opinions on what they think was best. And here were some of the comments they came up with, which were hugely insightful. The first one on the top, you can see there's an arm in a cast with a few digital kind of cartoons in the background. And the one below is an actual bone that's broken with the digital network behind it. And children said, you know, the number one logo was, it could be an adult, it could be a child's arm. It's not very clear from that. So that was a little bit of a negative for that logo. They felt that also the arm being in a cast kind of signified that the bone was healing, whereas this study was about detecting the fracture, not about healing. And so for those reasons, they really liked logo number two. They also thought logo number two with the color scheme was way more eye-catching and bold. And they really liked that rather than the more muted and demure coloring of logo number one. So that then became our logo and branding for this particular study. We then went ahead and designed a website where we could talk about what this project was all about. And this was an ongoing process throughout the study. So here are just some snippets of the website that we eventually came up with. You can log on to it. It's www.fracturestudy.com. And you can see the logo is first and foremost on our landing page. We also created little animated graphics that you can see here on the second middle picture, which highlight what a broken bone looks like. Why is it different in children? What does it mean? What can be done? What's AI involvement in this? And we also put a little bit at the bottom of the landing page about how you could get involved as a parent, as a child, with a survey that we were then subsequently going to do, or as a radiologist or a healthcare professional if you wanted to give your input on how the study design could be better. Some of the comments I got when I presented this website in its final form after lots of discussion included things like, it looks cool, they really like the color scheme, they really found it to be easy to read and to see the graphics, and the layout was said to be very professional and easy to navigate as well as straightforward to use. So that was a really great outcome and creative endeavor from the collaborative work with the patient public group as well as with the academic side of things. I mentioned earlier that we were setting all of this up in preparation for a national survey to be done to hear the voices of more patients and young children across the country. And so that brings me to our national survey. Now, this was a survey that would require a little bit more input and more detailed input in kind of coming up with the questions and the design and the layout and the language. So, in preparation for this, we created a fracture study steering group, which took a few members of the YPAG and the PCAG group who were really interested in wanting to dedicate more time and more energy to this specific project. So, from that, we had about 4 different YPAG members and 3 PCAG members who then became our fracture study steering group. In designing what kind of survey we wanted, at the time of designing, there was this one publication that was available where a group in the Netherlands had published on a validated and standardized questionnaire about AI in radiology. So we felt this was a good place to start with the types of questions we might want to include and the kinds of domains and areas of AI use in healthcare that we might want to explore with children. I created a preliminary draft using some of the questions from this particular study and asked the children and the parents and carers how they felt about the questions and whether or not they felt some of them needed adapting. And this, again, was an iterative process where there was a lot of back and forth emails, lots of marked up documents, lots of ideas and comments, as well as a few face to face and virtual meetings as well. So, things that they told me about were they really didn't like the way that the original draft was written in third person. They felt that asking people to identify and agree or disagree with certain comments phrased as I feel or I think or it is important to me was a lot more effective than saying, you know, one would expect this or one would want this for AI. So that was reworded to be more personalized. We reduced the number of questions so it wouldn't be quite as lengthy and tedious to fill out. And they gave me a lot of track changes on processes and wordings that we included. We had a discussion on whether or not we should make it more fracture focused or whether there should be a survey just about AI in healthcare in general. And it was felt at the end that because this was a fracture study, that we would phrase the questions as an example of a fracture and using AI in the fracture process, because it would be a bit more tangible for the public to understand what AI was and an actual use case example rather than it being very generic and very waffly. So that was what we really focused on. There were some questions at the end that said, would you change your mind if this was a different kind of disease that we were talking about or healthcare process? But predominantly our questions were focused around fractures to make it more easily understandable. And we did have a couple of different versions of this survey. We asked the same questions, but we used one in a child-friendly version with simplistic languages that we tested with our YPAG group and made sure that they felt it was easy to understand. And we aimed the survey at ages 7 and above. And we had a separate survey for parents and carers, which were used in a slightly more professional grown-up language, as that was felt more relevant to older adults who wanted to take part. In order to kind of understand what was going on and why this was important, we also created an animation video so that people could see how an AI may fit into the care pathway and therefore could answer questions in the survey a bit better. And that, again, was a thing that we created together, a lot of back and forth about whether or not they liked the animation, what kind of cartoons and voices should be used. And I'll just play that to you now. It's relatively short, only a minute long. Artificial intelligence be used to make decisions in hospitals? Intelligence means using a computer to do things a human would normally do, such as complex calculations and analyses. Computers are so powerful these days that we can use them to run programs that help with jobs done by doctors and nurses, like looking for broken bones on x-rays. But just because we can do this, is it right that we should? On the one hand, computers don't get tired or need a rest. They can keep performing well at all times of the day. And you don't need to keep training them like you do with new doctors and nurses. Computers may be more accurate than some humans. On the other hand, they can also make mistakes. And if the program breaks down, it could be a big problem. Some people also think that humans may get lazy and rely on this instead of learning or thinking for themselves. What do you think? Would you be happy for artificial intelligence to check all future scans for you? Let us know by joining our survey. Thank you. That was the animation that was put on the website, including QR codes on how to fill out the survey forms. We got a lot of help from Gosh Communications to put the survey and the QR codes on the Gosh website. We also collaborated with the Brittle Bone Society, which is a charity that represents children with osteogenesis imperfecta and brittle bone disease because they are more likely to fracture, and asked them for their help and input from their members as well. And we also emailed and contacted a lot of schools, primary schools, secondary schools, as well as universities across the UK, and shared with them this poster on the right-hand side of your screen right now, asking for help from young adults as well as children from ages 7 and above. And we cut it off at age 23 because we wanted to include as many young children and young patients as possible. During the time that the survey was open, which was for about a year, we collected 171 responses from all 4 nations across the UK. Although the most frequent responses were from London, this was only accounting for 27 of them overall. We did have one member run respondent who was age 6, and there was a comment in there that their parent helped them and talked to them through the survey. So very grateful for them taking part. But we also included a wide range of ages, as you can see from this bar chart, and also males and females across the board. We also had quite a lot of representation from different ethnic groups, as you can see in the pie chart here. For the various domains, we asked how people felt about accuracy, accountability, ethics, resource allocation, and collaboration when it came to the use of AI for fracture detection on scans. The ones that I've put in boxes in red here are the ones that scored the most highly in terms of our respondents agreeing with those comments. So things like, if AI is used for my scans, I want to know how accurate it is when I receive my scan results. So keeping in the loop, knowing about how the AI was used and how good it is was really important to children and young adults. They also really wanted to prioritize accuracy over speed and efficiency. They really felt that quality and accuracy was of paramount importance to them. And they really wanted doctors and nurses to still be in the loop. They felt that AI should be used to check human judgment, not to act on its own in any kind of autonomous way. When we asked different children and young adults what they felt about AI, depending on their own personal lived experiences, we actually found that those who responded that they had fractured a bone before and when it was missed were really highly more likely to agree that AI would be helpful than those who either had fractured but it wasn't missed, or those who had never broken a bone or weren't sure and couldn't remember. So it really shows that when patients felt that they had something missed, they really, really strongly felt that an AI could have done more to help them. And they were very open to this kind of digital innovation being introduced. But it also highlights that just because you ask one type or group of patients, that they may be very biased. And so it was really important to highlight this and get a wide range of opinions from lots of different patients and young adults and children. This was accumulated in a publication earlier this year, which was great. So it was a great piece of work that we did together. And Lauren Lee, who was our YPAG representative, also helped very much in writing up this study and was the first author on this paper published in European Radiology. We also acknowledged all of the members of the fracture study steering group in our acknowledgements on the paper. So it was a great team effort and really, really great news for everyone involved. I mentioned earlier that we did a concurrent survey looking at the parent views and carer views, and that is currently being written up, and hopefully we'll get that published soon and also include our YPAG group on that. So I'm now just going to hand over to Deirdre and Lauren. Deirdre was the PPYE manager for research at Gosh, and she interviews Lauren, our lead author, here in a video that they pre-recorded for this talk.
Yeah, I'm really pleased to be able to reach out to Gosh conference attendees to talk more about my involvement throughout the fracture study cycle and the skills I've gained too.
That's a really good place to start actually on your journey, building your skills and getting involved in research. So I know you joined Gosh Young Persons Advisory Group for Research way back in 2017 and that you took up the Young Facilitator role in 2022. Can you tell us a little bit about that, about you joining, etc.?
Yes, a friend spoke really highly about all the work the young people did. So I came to my first session in November 2017 and was amazed by how friendly and insightful the group were and never looked back. We have 6 day-long meetings a year where researchers share their work, so there's such a broad scope of topics we learn about. The research provides a fantastic springboard for discussions, and we all can contribute our ideas and experiences in shaping health research.
Well, that's a really good message actually to send out to GOSH conference attendees today about having patient and public involvement in research throughout the research cycle, and we're going to touch on that in our Q&A. So are you ready?
Absolutely.
Let's go. So I know that GOSH YPAG first got involved in the very early stages of the fracture study research design in 2020 when Dr. Shelmerdine attended one of your meetings. But how then did you continue your involvement?
Yeah, so at the time I was midway through medical school and was learning about bone growth. And I found it so interesting learning about all the challenges when making fracture diagnoses and what tools and technologies that could be used to diagnose medical conditions. I was really struck by Dr. Shelmerdine's enthusiasm and eagerness to amplify children and young people's voices, which got me really excited about the study. So I was really happy to hear that I could also join the PPI steering committee along with the other GOSH YPAG members so that we could share our opinions on what we thought about new technology. And with Dr. Shelmerdine's expertise, I helped amend the plain English summary, advise on outcome measures, and also helped co-design a research participant AI survey for children and young people.
So looking back at the co-design of the AI survey, can I ask you, what do you think was challenging about designing the AI survey for children and young people compared to other surveys?
So the aim of our study was to understand children and young people's opinions on AI. So our main challenge was designing an appropriate survey for children. This meant breaking down and trying to really understand their lived experience of broken bones, X-ray, experience with healthcare professionals, and artificial intelligence. I'm really grateful for the PPI steering committee and discussion with YPAG, who provided really valuable feedback as they also highlighted the importance of how we can make our surveys accessible for children and young people of all ages and ability.
That's really interesting, and it makes me think a lot about how patient and public involvement is such a reciprocal activity, isn't it, in terms of gains, both for the research teams and PPI representatives.
Yeah, but also feeling part of a team, I felt competent to then ask you and Dr. Shelmerdine if there were any work experience opportunities in terms of analysing the research findings, as I wanted even more involvement.
You were really proactive, which was fantastic. If you can cast your mind back then, what did you find interesting or surprising about the survey results?
I think the really interesting thing is that we always assume that children and young people are so well versed with technology, so might not have the same reservations of someone who is older. However, this study showed that young people are really mindful of the limitations and risks of AI, such as through diagnostic mistakes or risk of cyber attacks. Also from the survey, the majority felt that AI should not be autonomous. If AI was to have a place in healthcare, it should be done under close supervision with healthcare clinicians, because it can't take into account all the human factors and feelings that go with healthcare. I think I was really impressed by their thoughtfulness and consideration of AI in healthcare.
It's amazing, isn't it? We think this all the time with PPI. It always brings up more than we expect. So on reflection, what do you think the survey, why do you think the survey is important for making appropriate AI for children?
If we look at the trajectory of healthcare in the modern era, we can see that technology has been used more than ever and is only going to be more integrated to advance care and improve efficiency. So there's a lot of discussion about how AI can help to facilitate this too. Until this study, no one has really asked the younger generation how we feel about it, especially as we'll be all growing up alongside AI developments.
Yeah, and we speak a lot, don't we, about no research about me without me when we speak about children and young people. So it just makes perfect sense. Why wouldn't you go out and ask young people what they think? So now thinking about your journey as a junior doctor, as you move on and moving forward in your career, how do you think knowing the survey results will make any changes to how you'll be working with patients in the future?
As a doctor, it's made me really mindful about how children and young people perceive care and how each interaction with healthcare makes a lasting impact on their experiences and memories of health. It was clear through the study that it's important that we continue to inform and involve young people in their own care. There's absolutely no value in having a diagnostic tool or treatment without the backing of patients themselves.
Absolutely, that just makes perfect sense. And reflecting back on your patient and public involvement throughout the research cycle, you really have gold star involvement and engagement in this project. We just want to thank you so much. You've gone on to be a lead author on the research paper, How I Would Like AI Used for My Imaging, Children and Young People's Perspectives, which is really fantastic. And I know that Dr. Shelmerdine and myself are so happy that you've been involved and so grateful. So finally, any last message for our audience today?
I really wanted to shout out Gosh YPAG for thrived under your capable leadership, Deirdre, as well as the children and young people who participate in our project, as they play an integral part of how technology may be incorporated into children's health in the future. I'm also very thankful for Dr. Shelmerdine for giving me the opportunity to get so involved and her fantastic guidance, which is an important lesson for me, that if someone or something catches your interest, there's no harm in asking them to get more involved, as you never know where it will take you.
Absolutely, and you've been so proactive. Thanks so much for sharing your experience with us, Lauren, and see you at the next Gosh YPAG meeting.
Great, thank you so much. So that concludes some of the survey work and what we've done up to date, but there's more work to be done, as always. So what have we done as well in the background? A very capable PhD student, Kato, who's an engineer, has created an algorithm based on a multicentric data set of pediatric radiographs that we've collected across the country, and developed an algorithm that can detect fractures. He started off with the wrist first, but there are other body parts that we are working around towards. So that's in progress. We've also now in the midst of doing a giant multi-reader study where we're asking various doctors of different specialties, different experience levels, from emergency, orthopedics, radiology, to look at some x-rays without AI and then again with AI, and seeing whether or not they're more accurate in their detection of fractures, and also whether that would change their decision as to what to do with the patient. So following on from one of the feedback from the PPIE group that they suggested at the start of the study plan. So that's underway right now. Further to this, we've also taken this further and applied for another follow-on grant that we were successful in doing and recently announced, which was the AWS Imagine grant. And I just want to shout out and say a big thank you to the Drive team as well for collaborating on this and the success in this. So very quickly, this particular project was trying to see if we could get an AI to detect fractures on these plain radiographs. But taking this further, we thought, how about not just looking for the fractures, but also being able to tell us what type of fracture it is, and then referencing any current guidelines and making a suggestion on what is the current standard of treatment of this type of fracture as a guidance, not as a way of taking over control from the doctors or the nurses, but more to let them know, because it's hard to keep up to date with so many guidelines, as to what is the standard of care. And then they can decide based on who they see, what patient they've got in front of them, what other comorbidities are going on, whether or not they want to take that guidance up or do something different. But at least they know. And then based on that, could we take it even further and get AI to generate a personalized care letter for the patient? How should you manage your fracture? And maybe even a draft letter to the GP or to the orthopedic surgeons as necessary, based on what this AI is seeing on the X-ray. Again, this is going to be a pilot pathway, and it's very, very innovative and cutting edge. We're not suggesting that this is going to be in practice anytime soon. It's more pushing the boundaries of what is possible. What can we do? How can we stretch what we have already to make the best use of it? And as I said, really happy that this has been successful recently, but this, again, even taking this further, hasn't been without YPAG and PCAG input. We had a meeting last year when we were already kind of thinking about how we could do this, and these were some of the comments we had, things like, it's a great idea, but doctors shouldn't just follow the guidelines without making up their own decisions. I want it to be emphasized that this is assistance, not being relied upon. Not all treatments for broken bones might be similar in all patients. Some of them may have special considerations, so we need to think about that. All great comments and things that we've taken into account and will continue to as we progress with this new project. So it was great to be the only hospital outside North America to receive this Imagine grant on this fracture study project, taking it forward and pushing the boundaries. So thank you very much for your time. I'd just like to conclude by saying a big thank you to the Fracture PPIE steering group, and also a massive thank you to all of the people involved in the wider fracture study group as well.
Many thank you, Susie. They're wonderful to see such an insightful study, and also the how you've integrated the PPIE services into the study itself as well. Just got time for one question. How far are we away from using neural networks for detection in other more complex imaging modalities like CT and MRI?
I think we're quite a long way off. Never say never, but the fact is, for us to use AI in clinical practice, they need to have regulatory approval, and that process can take a long time. Although there are many AI tools available for radiology, less than 2% are actually validated and appropriate for pediatric use. So right now, we're really in the minority case, but I'm trying to raise awareness that we do want to be more inclusive with the AI that we develop so that we can include pediatric patients in this. Most of the tools at the moment that do refer to pediatric care are mostly radiographs or ultrasound rather than CT or MRI. But in the future, that might change. We do have some tools for adults, and that could be extended to include children, but they really do need to do more validation work and include more patient data in order to know it's safe for that use.
Great. Thank you, Susan, and thank you to Lauren and Deirdre for their contribution today.